board bombs.
I know everyone's on the edge of their seats. Part 2, bringing to you live here, procedural sedation. Some people listen to this episode, I'm sure, and they emailed us actually, and they said, I haven't been able to do a procedural sedation. I've been waiting for part 2. I've had to hold them all for a week. They've been waiting. Let's do the question. Let's dive in here. Board bombs again. Emergency medicine board bombs to be exact. During procedural sedation with propofol, a 62-year-old patient develops hypotension. Which of the following is the most appropriate initial intervention? Choice A, administer an IV fluid bolus. Choice B, administer epinephrine IV.
Ooh.
Choice C, switching to ketamine for sedation. Choice D, start a norepinephrine drip.
Before we get into the answer choice, shout out to EM News, our only sole sponsor, and shout out to our premium podcast, EM Rapid Bombs. You can find EM Rapid Bombs on our website, emboardbombs.com, and then click on the question to make. You can sign up right there. Takes like 2 clicks to sign up. It's a great way to support the website, the podcast, and everything we do. And honestly, it's a great way to keep up to date on content and knowledge in 3 to 4 minute episodes. Hey, talk about the right answer here, Britt.
Hey, before I get there, just want to quote us that we've been mentioned on Reddit several times as an optimal study resource for boards.
Get out of
Just
here.
keep that in mind.
Nice.
Oh, yeah. We are
All
Reddit
right.
right now. Yeah.
The Reddit kids love us. Okay.
The Reddit kids. Hey, answer here. Choice A, administer IV fluid bolus, right? I think we all kind of knew the answer. Another bunny question, but good lessons here. So talking about propofol, we talked about ketamine last episode very briefly. Propofol is probably the most commonly used agent, I think, overall for procedural sedation. Yeah, especially around the across the healthcare system.
Yeah, I think mainly like in the adult population, right? I think ketamine tends to still skew more peds population,
for sure,
but adults for sure. Yep.
Absolutely, it's rapid onset, it's short duration, and it's easy to titrate. However, one of its major side effects is going to be hypotension. Almost all the time, this is transient, and it occurs because of systemic vasodilation and potentially at higher doses decreased myocardial contractility, especially older patients. This is very well tolerated in young people. Like sometimes you don't even bat an eye. You can unload a dose on them and it doesn't matter.
Yep.
In older people, you might just give like 20 cc's and it's like, oh boy. So the first step in managing propofol-induced hypotension is the easiest answer ever, which is let's just hang a fluid bolus. Most of the time, your expert nursing staff automatically have a bolus ready to go. They just hook it up to the patient. And they already anticipate this will be an issue. That's years of experience and years of dealing with silly doctors making mistakes. So starting with 500 to 1,000 milliliters of isotonic fluids and then reassessing the patient's response is the best choice here. What about the other answer choices here? Getting into those, choice B was talking about giving epinephrine, kind of aggressive. That's a little premature. I wouldn't do that. Not recommended on the boards or in life. Choice C, switching to ketamine.
We had to throw out just a funny.
I know we did. We had to give this an answer. That does, provide hemodynamic stability. I could see like a resident or student asking this. That's why I'm laughing. We both are. It's like I would ask like the student, like, what would you do in this scenario? And they're like, I mean, I guess I could just switch to. They're not wrong. They're not wrong. But it's awesome. Not practical. It doesn't address the actual hypotension. You would hold sedation for the moment and address the hypotension. And then, of course, choice D, starting norepinephrine is, again, premature. That's like second line for refractory cases. When complications arise during sedation, your ability to stay calm is important. We talked about last episode how critical it is as an emergency doctor to deal with that unpredictable nature of the emergency department, meaning that I'm going to sedate this patient because I have to, because in this situation, this is a procedure that's indicated. I don't really know or care about their fasting status. I've gone over the safe steps of sedating them, but it's not like that climate-controlled environment elsewhere in the healthcare setting. With that comes risks, and with that comes your ability to handle systematic troubleshooting when problems come up. And the big three categories are going to be airway, their blood pressure, and just the sedation depth in general, and dealing with making sure they're appropriately and safely sedated. Airway complications. This is the most feared one, obviously. And this is managed, though, with preparation. So the number one thing that'll come up in sedation, I see it pretty often, especially in the heavy-handed dosing administration some people do with sedatives.
And fast.
Is going to be,
and fast.
Yes, yeah, exactly. Apnea or hypoventilation. This is very common with propofol, sometimes atominate as well. If you see any hypoventilation on the capnography or just apnea, the first is to assess the airway position. You're going to immediately, without thinking, do a head tilt chin lift or a jaw thrust. This cures the problem the vast majority of the time.
Briggs, I think it's important to mention here that you're not waiting for that pulse ox reading to show 90%.
You got the end tidal, you're going with it.
You're focusing on that end tidal. That pulse ox, it's going to go at a later time. You are being proactive when you see that end tidal not being an end tidal.
Exactly right. Now, like I said, the jaw thrust or head chin lift is going to be by far the greatest solution here. That solves the problem. You're going to hold that position maybe for a minute or so, sedative kind of wears off, and then the patient's back to doing what they normally do. If this doesn't improve, though, that's when you got your bag valve mask right at bedside, because we told you last episode to have that ready, and you are providing them 100% oxygen. Preferably, this is a two-person show. You know, two-person bagging is always better than one, and so you should be the one either bagging or holding the mask seal with two hands, and then nurse or whoever's in the room with you, call for help, will be in there with you to help with bagging. Hey, so if that isn't working, let's say, okay, we did the jaw thrust, didn't work, and did the bag valve mask, didn't work. You are like in the range of less than 1% here of like problems of this. And if that happens at this point, you were intubating the patient. This is so super rare, almost always caused by you really messed up sedating this patient, like too much sedative. It happens sometimes, I guess, but if possible, you can bag the patient through it. But most of the time, if that point you are struggling, you are intubating them and dealing with the consequence later. And you already consented the patient. They know you could intubate them. So the second thing that can happen with the airways is laryngospasm. We talked about this at the last episode. This is extremely rare, so rare, like less than I think 0.5%. But it's serious, especially with ketamine. The first step is positive pressure ventilation with PEEP. And this is going to be a test question here. It's going to say, hey, you have this. It's always going to be a pediatric patient too. They always love giving you the peds patient with laryngospasm. And on the test, going to be, they went apneic. You gave them ketamine. What's the next answer? Well, you're going to try the jaw thrust. It's not going to work because it's laryngospasm. And then you're going to do the bag valve mask with PEEP, positive pressure ventilation. Often this resolves the issue. It forces air through that laryngospasm. If that doesn't work, you're going to have to talk about paralyzing the patient and being ready to intubate, which is unfortunate. So why don't you cover the last two complications, moving on to hemodynamic issues.
So hemodynamic complications. So talk about airway. Now you're cycling the patient's blood pressure. I think it's important to mention you're cycling the patient's blood pressure every few minutes. This is not one of those things where on the monitor, you're cycling the patient's blood pressure every 30 minutes, right? So you need to change that monitor setting. And hypotension, we're going to talk about that first. So propofol, we talked about, can cause vasodilation and myocardial depression, especially in older patients or patients who are hypovolemic. So the first step here is going to be IV fluids. We talked about that as an answer choice in the past, right? It's IV fluids. Start with 500 or 1,000 mLs of isotonic fluid and reassess. If fluids aren't going to resolve it, then you can consider a low-dose vasoactive agent like phenylephrine or ephedrine, but almost always fluids should work. Don't, obviously during this time, be giving more propofol. Number two, bradycardia. I know, right? This can occur when you have, opioids on board, with your sedation. That should resolve. It really should. It's frankly, it's quite rare. And lastly, we're going to talk about hypertension or tachycardia. We mentioned with ketamine, a bit of a sympathomimetic, which you can use to your advantage as well, with this. But in patients with underlying cardiovascular disease, you can have some hypertension, tachycardia. What do you do here, Briggs?
Let it ride.
There you go. Another thing that we're going to talk about, and another kind of category of challenges, I guess, is there are really two things. One is inadequate sedation. So the patient's still moving around. So you can give incremental doses of the sedative. I think it's important here to always remember you're the one in control of that procedure. Ortho or other service who is doing the procedure or the other part of that procedure, sometimes if you're doing this in collaboration, yes, it could help them to achieve a better optimal outcome if you're giving them even more sedation. But if that's going to be a detriment to that patient's airway, you are never crossing that line. The airway is always the most important thing to maintain. Hemodynamic stability is the most important thing to maintain. There's no point in that hip being put back to place when that results in the patient requiring intubation. That patient can frankly go to the OR if that's required, right? Lastly, we're going to talk about emergence reaction. So we talked about that with ketamine. Sometimes these patients can wake up, they can experience some agitation or hallucinations. In these cases are pretty reassuring. If they're very agitated, you can give them benzodiazepine. But those cases tend to be rare. But we've all seen it in ketamine, especially in adults. Sometimes they can have a bit of a reemergence phenomenon. Hey, wrap this up real quick.
Yeah, so hey, let's do a quick summary here. How to handle complications during procedural sedation. Airway, be prepared for apnea, laryngospasm. Bag valve mask, suction are your first line tools. Jaw thrust first, followed by bag valve mask, followed by intubation, unfortunately, if needed. Hemodynamics, Dr. Hussein covered these. Monitor for hypotension, give a fluid bolus early. If that doesn't work, move on to epinephrine or norepi pushes or a drip if that continues. Obviously, you're halting sedatives at that point. And then, of course, sedation depth, adjusting the dosing as needed. Start low, go slow, and be ready to address any emergence reactions, typically with just reassurance. If that doesn't work, a small benzo dose is a good choice. And that is it. Check out Rapid Bombs.